Today, as we can continue our journey through case-based primary care, we're going to talk about starting insulin in the patient with a new diagnosis of type 2 diabetes. We'll talk about when to start insulin, when you might think about sending the patient to the ER, and most importantly, share decision-making about starting insulin. Remember, when you diagnose type 2 diabetes, this is a life-changing diagnosis for your patients. Spend the time to explain it to them. It's going to take a lot of visits to get all the information across. So we'll say we have a 27-year-old male coming in with symptomatic hyperglycemia, fatigue, blurry vision, weight loss, polyuria, polydipsia, polyphagia, and we do an RBG 324, and his in-house A1C is 13.5. By definition, this meets the diagnosis of type 2 diabetes. We'll talk about that in another podcast. Right off the bat, the first thing, sick, not sick. Is there a concern for HHS or DKA? Do we need to send the patient to the ER right now? If there's a concern for HHS or DKA, then we're probably going to send the patient to the ER, and that's beyond the scope of this video. But basically, we're asking how symptomatic is the patient? Is there severe nausea and vomiting, abdominal pain, confusion, altered mental status, decreased urine output? Those are reasons to send the patient to the ER. But otherwise, how symptomatic is this hyperglycemia? Think about your 3 Ps, polyuria, polydipsia, polyphagia, blurry vision, polyarthralgias. Is there generalized fatigue, maybe even some catabolism, weight loss? So when I'm diagnosing type 2 diabetes, I'm thinking, where is the patient on their diabetes journey? What do I mean by this? Is it somebody that you've been following closely and you know they've just gone from prediabetes to diabetes? Or is it a new patient to your clinic coming in with symptomatic hyperglycemia and you have no idea how long they've been like this? As we're going through a new diagnosis of type 2 diabetes, think back to motivational interviewing. Where in the stages of change are they? This is really important when it comes to starting insulin. Across multiple guidelines, we have consensus that generally, if the patient is symptomatic and or has an A1C over 10, we're probably going to want to start insulin. So to include the ADA as well as the American Association of Clinical Endocrinologists. When we're starting insulin in a patient with new diagnosis of type 2 diabetes, we frequently talk about starting 10 units every night. Where does this number come from? 0.1 units per kilogram is a good starting dose, and if the average patient weighs 100 kilograms, that's where 10 units comes from. We can always go up, but hypoglycemia can be a medical emergency, so I always start low and go slow. As you have a new diagnosis of type 2 diabetes, follow-up is key, and so really leverage your team-based care, nursing, medical assistants, community health worker, everybody that you've got on the team. Takes many visits to cover the education. Frequently, I'm doing monthly visits, and then every other week they're coming in with the nurse, for example, for insulin titration or additional medication and nutrition education. So to summarize this bird's eye view of starting insulin for a patient with a new diagnosis of type 2 diabetes, don't be scared to start insulin. Somebody that's coming in symptomatic can feel a lot better. Be prepared to navigate the different stages of change and spread things out over a lot of visits to make sure that everything sinks in.